Usually, when you think about taking care of your skin, you picture a process that is, fundamentally gentle.
Right, like soothing lotions, soft towels, things like that.
Exactly. Maybe sitting back with a cooling cucumber mask. The whole industry built around consumer skincare is focused almost entirely on protection and just, well, calming things down.
Which makes total sense for your daily maintenance. I mean, the primary biological function of your epidermis is to act as a barrier.
To keep the good stuff in and the bad stuff out.
Exactly. So intuitively, you want to preserve that barrier at all cost.
But the moment you cross the threshold into clinical dermatology, that gentle script goes completely out the window.
Oh, totally out the window.
Suddenly, you are looking at medical procedures that purposefully vaporize water molecules inside your face. You're looking at protocols that risk waking up dormant viruses just to stimulate a reaction.
And official hospital guidelines declaring war on something called ritualistic practice.
Yeah, that part blew my mind. So, welcome to today's deep dive. To figure out how this all works, we've stacked up an incredible variety of sources today for you.
We really have. We're looking at NHS hospital laser recovery manuals, clinical evaluations of post-procedure healing gels, and the 2017 British Association of Dermatologists Rule Book on Contact Dermatitis.
Along with international wound care consortiums. And what it all paints is this picture of an organ that is in a constant, highly paradoxical state of destruction and reconstruction.
It really is a paradox.
Yeah.
Today, we are exploring the extreme measures we use to purposefully damage the skin for rejuvenation. We'll get into the rigorous biological science of raw wound healing, too.
And how the medical field manages the aftermath when your skin goes to war with everyday substances, right down to how we treat the permanent visible marks left behind.
So we should probably jump right into the deep end with intentional injury.
Yeah, let's start there. Because to truly understand how your skin heals, you first have to look at how we, well, purposefully destroy it.
Which sounds brutal, but it's effective.
Right. CO2 laser resurfacing is this massively popular cosmetic procedure for wrinkles, severe acne scars, sun damage, you name it. But the actual mechanics of what that machine is doing to your face are incredibly intense.
Oh, incredibly. It doesn't just, burn the tissue indiscriminately like a hot iron. The precision is the whole point.
So how does it actually work on a cellular level?
Well, a CO2 laser emits an intense beam of light at a very specific wavelength. And that wavelength is highly absorbed by water.
And since your skin cells are mostly water.
Exactly. The laser targets those internal water molecules. It heats them up so rapidly that the water literally boils and turns into vapor.
Oh, wow. So the cells just explode.
They explode from the inside out, yeah. This completely removes the damaged outer layer of the epidermis while simultaneously driving intense heat down into the deeper layer, the dermis.
And it's that specific thermal damage in the dermis that acts as the ultimate trauma signal, right?
Right. Your body senses the extreme heat, assumes it's under severe attack, and just floods the zone with resources to produce fresh, tight collagen.
That trauma signal is basically the entire goal of the procedure. Now, doctors approach this in two different ways, based on the sources.
Yes, the traditional method is fully ablative.
Meaning the laser vaporizes the entire surface layer of skin across the whole treatment area. Like you are essentially removing the canvas to weave a new one.
That's a good way to put it. But the newer, highly common approach is fractional laser treatment.
Fractional makes so much sense when you think about it like aerating a lawn.
Oh, I like that analogy.
Yeah, if you've ever seen someone maintaining a golf course or a yard, they don't tear up the entire field to get healthy grass. They bring in a machine that punches thousands of tiny, deep plugs of dirt out of the ground.
Right.
It creates these microscopic columns for water, air, and nutrients to get deep into the soil, but it leaves the grass immediately surrounding those holes completely untouched.
That translates perfectly to the cellular level. A fractional laser punches thousands of microscopic thermal holes into your skin.
But because it leaves the surrounding tissue intact,
those unharmed areas act as biological reservoirs. They contain healthy skin cells that immediately rush in to repair the microscopic columns of injury.
which drastically accelerates the recovery timeline compared to tearing the whole surface off.
Exactly. It's a much faster heal.
But even with that accelerated timeline, I mean, if you read the clinical notes on the immediate aftermath, it is visceral. Patients report smelling smoke and fumes during the procedure.
Because their cells are literally being vaporized.
Right. And immediately after, the skin is covered in thousands of microburns, it swells dramatically, and it begins to ooze this clear, straw-colored, serous fluid.
I know that fluid might look alarming to a patient, but Biologically, it's just a masterpiece of evolution in action.
What is it exactly?
Serous fluid is essentially blood plasma. When the laser breaches the barrier, your blood vessels dilate and become more permeable, rushing that fluid to the surface.
To clean things up.
Yeah, it is packed with white blood cells to prevent infection and enzymes to start clearing away the vaporized dead cellular debris.
And then over the next few days, that serous fluid dries up and forms tiny crusts over every single microscopic laser column.
Leaving you with a face that feels entirely like fine sandpaper.
Yeah, the leaflets warn about that texture. But the part that really stood out to me in the medical spa and NHS leaflets is the unintended collateral damage of causing this kind of systemic shock.
It's a huge shock to the system.
Right. When you traumatize the local immune system this severely, you can easily wake up conditions that were perfectly dormant.
The herpes simplex virus is the classic example here.
So like cold sores.
Exactly. If a patient is prone to cold sores, their immune system usually keeps the virus suppressed deep in the nerve bundles. But when you hit the face with a laser, the local immune defenses are entirely diverted to handle the massive burn trauma.
So the virus basically senses that the guards are busy.
Yes, it senses that lapse in security and can trigger a massive outbreak across the newly vulnerable raw skin.
Which explains the strict protocols demanding prophylactic antivirals. Like, you have to take Aciclovir before you even sit in the laser chair.
You absolutely do. And then you have the melanocytes to worry about.
The pigment cells, right.
Right. The thermal injury poses a massive threat to the cells that produce your skin pigment. If you damage them, or if the inflammation overstimulates them, you are looking at hyperpigmentation.
Where patches of skin turn permanently dark.
Or hypopigmentation, which leaves you with permanent white spots.
And protecting those melanocytes basically dictates the most demanding rules of the recovery phase.
Oh, the rules are intense. In the immediate aftermath, the fluid pooling and swelling are so severe that patients are instructed to sleep strictly propped up on raised pillows.
For like the first 4 days, just to let gravity help drain the face?
Yep, but the long-term rule is sun protection. Patients are required to wear SPF 30 or higher every single day for a minimum of 6 months.
6 months. Just because the melanocytes are so fragile during that reconstruction phase that even walking to your car on a cloudy day could trigger a permanent pigment change.
The UV vulnerability is absolute. There is no wiggle room.
So creating those micro reservoirs of trauma is really only half the battle. Once you've vaporized thousands of tiny columns into your face, you are left with an incredibly vulnerable canvas.
And how you manage that raw skin dictates whether the procedure is a success or if you end up with lasting damage.
Which takes us straight into the Wounds International Consensus document. And this introduced a concept I found completely fascinating.
The battle against ritualistic practice.
Yes. The consortium is very firm on this.
They really are. They define therapeutic wound cleansing as a highly deliberate medical act. A practitioner, or even the patient, must actively evaluate multiple zones.
Like the wound bed itself, the edge of the wound?
The peri-wound area just outside the edge and the broader surrounding skin. Ritualistic practice is the exact opposite of that.
It's basically habit-driven nursing. The documents describe it as the mindless swiping of a wet wipe, or just slapping on a standard ointment because it's what the clinic always does.
Without actually stopping to ask what the microenvironment of that specific wound needs today. And ritualistic cleansing actually damages tissue.
Wait, really? Just cleaning it damages it?
Yeah. If you scrub a healing wound out of sheer habit, you destroy the fragile new cell networks trying to bridge the gap. You disrupt the delicate balance of moisture and temperature required for optimal enzymatic action.
Which brings us to the actual grueling post-laser routine prescribed to patients. To avoid infection and promote that delicate healing, the NHS guidelines require patients to wash their raw, painful faces 4 times a day.
Specifically at breakfast, lunch, dinner, and supper.
Using tepid water, a gentle cleanser, patting it dry with sterile gauze, and then applying a thick layer of petroleum jelly.
Petroleum jelly, or petrolatum, is an occlusive agent. It has been the absolute gold standard in dermatology for decades.
Because it seals everything in.
Exactly. It forms an impermeable physical barrier over the skin, locking in moisture. A moist wound environment is non-negotiable.
Why is it so strict?
Because those new repairing cells literally need a liquid medium to migrate across the wound bed. If the wound dries out and forms a hard scab, cell migration halts entirely.
And the risk of scarring skyrockets.
Exactly.
Okay, looking at this from the perspective of the patient, though, the biology makes sense, but the reality sounds miserable.
It is incredibly tough on the patient.
If I have to slather a thick, greasy layer of petroleum jelly onto a red, raw face 4 times a day, I am essentially trapped in my house.
Pretty much.
You can't put mineral sunscreen over a thick layer of grease. You can't apply makeup. You can't step outside without every particle of dust or hair sticking to your face.
Right. There comes a point where the gold standard treatment becomes a massive compliance issue.
People just give up and stop doing it.
Exactly. And that exact friction between biological efficacy and patient compliance is what the dermatological community has been trying to solve.
Which brings us to this highly revealing split-face study published by LiveDerm.
Yes. Researchers wanted to see if a newer alternative, a medical-grade silicone gel, could replace the traditional petrolatum-based ointments for post-laser recovery.
The setup for the study is brilliant. They took 10 patients who had just undergone erbium-YE fractional ablative laser resurfacing.
A very intense procedure.
Right. And for 7 days, they applied petroleum jelly to one half of the patient's face and the new silicone gel to the other half.
That split face design is crucial because it controls for individual healing rates, age, and skin type.
Because it's on the exact same person.
Right. You are watching 2 different treatments race against each other on the exact same biological canvas.
And looking at the data, the long-term destination is completely identical. By day 60, both sides of the face showed the exact same level of aesthetic improvement and healing.
So it's not that the silicone gel inherently builds better collagen or anything like that.
The real difference is entirely about the misery of the first week. The silicone side showed significantly reduced early erythema.
Meaning that severe raw redness faded much faster.
Yeah, and a lower rate of hyperpigmentation. But to me, the ultimate advantage was the physical property of the gel itself. It dries into a thin, breathable film.
That breathable film is the real clinical breakthrough here. Because it dries down flat, it allows the patient to apply their mandatory mineral sunscreen directly over the healing skin.
They can apply cosmetics. They lose that heavy, suffocating sensation associated with petroleum jelly.
So it's not a matter of the silicone possessing some magical cellular healing property that petrolatum lacks.
Right. It's that the silicone gel makes the patient's life bearable enough that they can actually follow the strict 6-month sunscreen rules without abandoning their normal lives.
Medical practice often evolves exactly this way. If a treatment is biologically perfect but socially impossible, the treatment that guarantees patient compliance will ultimately produce better clinical outcomes.
That makes total sense. So we've been looking very closely at skin that we intentionally destroy and carefully rebuild.
But your skin is constantly interacting with the world.
Right, and sometimes it breaches the barrier unintentionally. It goes to war with everyday substances it mistakenly perceives as a threat.
This takes us out of the realm of cosmetic resurfacing and into the medical management of contact dermatitis.
Leaning heavily on the 2017 guidelines from the British Association of Dermatologists.
Right. If you've ever dealt with an unexplainable rash, you know how frustrating the diagnostic process is.
It's maddening. And the guidelines make it clear that a doctor cannot simply look at the clinical features of your skin and reliably distinguish between an allergic reaction, an irritant reaction from a harsh chemical, or an endogenous flare-up like eczema.
Because the visible symptoms are almost identical across the board.
Which is why the diagnostic cornerstone is patch testing. The dermatologist applies a baseline series of common allergens to the patient's back, usually on a Monday, and then waits to read the immune response.
And the timeline for reading those results is a fascinating look into how our immune system is paced.
Yeah, they do the primary reading at day 4, but the guidelines explicitly warn doctors that if the results are unexpectedly negative on day 4, they cannot just clear the patient.
They have to bring them back for a second look on day 6 or day 7.
Why wait nearly a full week?
The reason for that delay comes down to the actual mechanics of allergic contact dermatitis. It is a delayed type hypersensitivity reaction driven by T cells.
T cells?
Yeah. T cells are essentially your body's slow-moving infantry.
So unlike a sudden histamine reaction where you break out in hives immediately after eating a peanut?
Exactly. Contact dermatitis takes time. When a trigger like a nickel watch band or a topical antibiotic breaches the skin, the immune system has to first recognize the foreign invader.
Okay.
Then, those localized cells have to travel all the way to your lymph nodes, present the invader to the T cells, multiply into an army, and then travel all the way back to the skin to launch the inflammatory attack.
Wow. So imagine you're the doctor reading that patch test on day 4. The T cells are literally still in transit.
Right, they haven't arrived yet.
You see nothing on the patient's back, so you send them home, telling them they aren't allergic to the metal they work with every day. You've completely missed the culprit purely because you didn't account for the travel time of the immune system.
And once they finally do identify the trigger, the treatments escalate from basic barrier protection creams right up to heavy immunosuppressants.
Like what kind of heavy hitters?
Well, if standard topical steroids fail, they prescribe topical tacrolimus to suppress the local immune response, or alitretinoin for severe chronic hand eczema.
They even utilize PUVA, right?
Yes, PUVA is a specialized form of phototherapy that uses ultraviolet light to literally dampen the overactive immune cells in the skin.
But the part of the British Association of Dermatologists guidelines that really changes the paradigm is how they evaluate whether those treatments are actually successful.
They rely on an international framework called the GRADE system.
And GRADE completely redefines the concept of a medical victory.
It really does.
Mhm.
Historically, clinical trials for dermatology were hyper-focused on physical metrics.
Like measuring the diameter of a lesion.
Exactly. Proving the new steroid cream made the rash 50% smaller, and that is certainly an important clinical endpoint.
Sure.
But the GRADE system challenges guideline developers to separate what is mechanically important from what is critical to the human being actually living with the disease.
And when they applied that filter to contact dermatitis, the top two critical endpoints for a successful treatment were return to or remain in work and improvement in quality of life.
They completely shifted the goalpost. They emphasize relying on assessment tools like the Dermatology Life Quality Index, or DLQI, and the Hand Eczema Severity Index.
So think about a mechanic or a surgeon dealing with severe contact dermatitis.
Right.
If a heavy steroid clears the visible rash, but leaves the skin on their hands so thin, painful, and prone to cracking that they still cannot hold a tool or scrub in for surgery.
Then that treatment fails the GRADE criteria. Getting the patient back to their livelihood is the paramount medical objective, not just achieving aesthetically clear skin.
That reframing makes so much sense of a recommendation later in the guidelines that initially caught me off guard. They list patient education as a prescribed medical treatment for occupational dermatitis.
Not just as a pamphlet handed out at the front desk.
No, as a graded clinical intervention on par with prescribing a pharmaceutical.
Because when the definition of success is keeping someone in the workforce, simply teaching them how to navigate their workplace hazards becomes the most powerful medicine available.
Educating a patient on the precise mechanics of hand washing, the exact material of gloves required to block specific molecular chemicals.
And how to read safety data sheets. It empowers them to break the cycle of exposure entirely.
It stops the T-cell infantry from ever being deployed in the first place.
Exactly.
So we've covered the controlled burn of lasers, the transition from occlusive ointments to breathable silicone gels, and the intense biological warfare of contact dermatitis.
But this leads to a very quiet, profound final stage.
Right. The T-cells have retreated, the immune system has calmed down, and the micro-injuries from the laser have completely closed up. The active biology is essentially finished.
But what happens when the patient is left with a permanent, visible reminder of the war?
This is where clinical dermatology intersects directly with psychology. And to explore it, we look at the Northern Ireland Formulary, specifically Section 13.8.2.
Which governs the prescribing of camouflagers.
Yeah. And the word camouflager immediately conjures up the idea of heavy department store foundation makeup.
But the formulary is incredibly strict. These are not cosmetics.
They are prescribable medical interventions for postoperative scars, deformities, and conditions like vitiligo where the melanocytes have been permanently destroyed.
The formulary outlines a very specific first-choice treatment called Dermacolor.
What makes it different from normal makeup?
It is a highly pigmented camouflage cream that must be set with a specialized fixing powder. That combination renders the application waterproof and sweatproof.
So the patient can live a normal, active life without fear of it washing off.
Exactly. But doctors cannot just write a prescription for Dermacolor because a patient has an uneven skin tone.
Right. Access is heavily regulated by the Advisory Committee on Borderline Substances, or ACBS.
The ACBS exists to navigate the exact gray area we are discussing. They evaluate products that sit on the borderline between a standard consumer cosmetic and a true medical drug.
Determining under what strict criteria a cream or powder elevates to the level of official medicine. And the ACBS criteria for prescribing a camouflager includes a line that is incredibly telling.
What's the line?
They allow it to be prescribed as an adjunctive therapy for emotional disturbances due to disfiguring skin disease.
Wow. If you connect that straight back to the grade system we were just discussing, it is a perfectly consistent medical philosophy.
You're treating the mind as an extension of the skin.
Precisely. The grade system elevated the patient's quality of life to a critical primary endpoint.
The medical establishment recognizes that a severe, visible skin condition on someone's face or hands carries a debilitating psychological burden.
It drives profound social anxiety, isolation, and clinical depression.
So prescribing a camouflage cream is not about indulging a patient's vanity.
Not at all. It is a formal acknowledgement that the emotional devastation caused by a visible skin disease is just as biologically real and harmful as an open, oozing wound. Treating the emotional disturbance is an essential part of treating the patient.
It really brings the entire journey full circle. We've traveled across the entire spectrum of how science interacts with the barrier between you and the outside world.
We started with the violent, calculated vaporization of cells using CO2 lasers, exploring how we purposefully trigger the body's trauma response to build fresh collagen.
We examine the demanding logistics of raw recovery and how transitioning from the traditional occlusive barrier of petroleum jelly to modern, breathable silicone gels dramatically improves patient compliance.
Giving them their daily life back.
We broke down the unintentional warfare of contact dermatitis, mapping the slow migration of T cells, and how the medical field uses the grade system to prioritize getting people back to work over simply clearing up a rash.
And we finished with the medical validation of camouflage creams, proving that healing the emotional scars of a skin condition is a vital, prescribable part of dermatological care.
It leaves you with something entirely new to ponder. Right now, we spend immense resources coaxing our skin to heal itself, burning it with lasers to force new collagen, or suppressing the immune system to stop it from attacking itself.
It's all about managing the natural biology.
Right. But as we get better at growing synthetic tissue in labs and our lasers get more microscopically precise, it makes you wonder, will we eventually stop trying to coax our natural skin into repairing itself?
That's an interesting thought.
Maybe the future of dermatology isn't about healing at all. Maybe we will just start seamlessly printing and swapping out the damaged layers entirely, completely bypassing the biology altogether.
The ultimate form of fractional resurfacing.
Something to think about the next time you're standing in front of the mirror. Thank you for joining us on this deep dive. Keep questioning the world around you, and we'll catch you on the next one.